And so it came to pass that we were summoned to examine the afflicted at Perinthus in that winter. Just after the solstice, a great change of the winds. Women, children, men were all struck with this illness and all fatigued by heaviness of breath and pulmonic affections. Of their persons, the whole body inspires and expires. The usual remedies were tried, namely purging and venesection, but none of them did any good. The cough of Perinthus. This is how Hippocrates, the father of Western medicine, described a seasonal affliction that spread far and wide from this port town on the Sea of Marmara and caused so much respiratory distress in adults and children alike. Could he have been the first to describe what we would later call bronchiolitis? It's difficult to take a single description of what was an ancient epidemic and know exactly what was going on. But what we do know is that the viruses that cause seasonal respiratory distress syndrome in infants, better known as bronchiolitis, have been around since ancient times and will likely be affecting babies throughout our lifetimes and far into the future. So, we'll have to get to know each other. Bronchiolitis is like the pneumonia you can't treat. We're really at the mercy of nature. Where we step in as clinicians is in supportive care. Let's clear up this phlegmatic mess today with bronchiolitis. Something wheezing this way comes. Welcome to the Playbook. I'm your host and coach, Tim Horechko. Bronchiolitis is a seasonal scourge that we encounter yearly in the emergency department. When it's cold or wet and people are more likely to be inside, that's when it strikes. Air pollutants may also factor in, and there's definitely a link in exposure to tobacco smoke and severity of exacerbations in young children. Respiratory syncytial virus is the villain of this story. It's the culprit in up to 90% of cases of bronchiolitis. The reason RSV is so nasty is the immune response to the virus. It binds to epithelial cells, replicates, and the submucosa becomes edematous and hypersecretes mucus. RSV causes the host epithelia and lymphocytes to go into a frenzy. Viral fusion proteins turn the membranes into a sticky goop. Cells fuse onto other cells, and you have a pile-on of multinucleated dysfunction. This mucosal chaos causes epithelial necrosis, destruction of cilia, mucus plugs, bronchiolar obstruction, air trapping, and lobar collapse. Think of your healthy baby's lungs like happy, puffy cotton candy. RSV turns them into wet, sticky goop. Other viruses can do this too. If it's not RSV, then their accomplices do it. Human metapneumovirus, rhinovirus, coronavirus, bocavirus, and influenza, to name a few. There can be co-infection with these guys as well. Up to 30% of cases have RSV plus a co-conspirator virus. RSV, though, is the crime boss of this syndicate. It causes the most severe course compared with the other viruses. The diagnosis of bronchiolitis is clinical. But how do we get there? Well, first there's age. The U.S. definition is for children less than 2 years of age, while the European Committee is more precise, including infants less than 1 year of age. The reason this is important is that toddlerhood brings with it other conditions that mimic bronchiolitis. The first-time wheeze in a toddler may be his reactive airway response to a viral illness and not necessarily bronchiolitis. On the one hand, the U.S. definition is inclusive, but on the other, extending the diagnosis out to 2 years of age can muddy the already sludgy waters. This explains some of the hubbub about bronchodilators that we'll talk about in just a moment. The classic clinical presentation of bronchiolitis starts just like any other upper respiratory tract infection, with nasal discharge and cough for the first 1 to 2 days. Only about a third of infants will have fever, usually low grade in the 38 degrees Celsius range. We may see the child in the ED at this point and not appreciate any respiratory distress. This is why precautionary advice is so important in general. Then, lower respiratory symptoms come. Increased work of breathing, persistent cough, tachypnea, retractions, belly breathing, grunting, and nasal flaring. Once lower respiratory symptoms are present, like increased work of breathing, they typically peak at day 3. This information may help us to make decisions or counsel parents depending on when the child presents and how symptomatic he is. On exam, you'll see a waterfall of mucus from the nose. It reminds me of the Japanese word for runny nose, hanamizu, literally nose water. With bronchiolitis, RSV is causing so much hypersecretion, it's like a faucet leaking. Think about what's happening in the lower airways. You'll hear fine crackles and wheeze. A typical finding in bronchiolitis is a minute-to-minute variation in clinical findings. One moment, the child could look like he's drowning in his secretions, and the next minute, almost recovered. This has to do with the dynamic nature of secretion, plugging, obstruction, coughing, dislodgement, and replugging. Even in the children who appear very well, I always go back to re-examine them on discharge, or if needed, I observe them for a short time. It's just so easy to be fooled by this classic ebb and flow of bronchiolitis signs and symptoms. Remember also that you can be faked out here. If there are no upper respiratory symptoms, it isn't bronchiolitis, regardless of the wheezing you hear. Is there a wheeze, but no hanamizu? No water dripping from the nose? Think cardiac disease. Think congenital airway anomalies like vascular rings, or think about just good old plain foreign body aspiration. Watch out especially for young infants, so those less than 3 months of age. Apnea may be the presenting symptom of RSV. Premature infants, especially those less than 32 weeks gestation, are at high risk for deterioration. Of course, if the infant, regardless of gestational age, had an apneic spell during the present illness, then that child is admitted. Various studies have shown that infants less than 1 month, regardless of gestational age, are at highest risk for apnea in RSV. They should all be tested and admitted. Well then, what do we do with the premature infant with bronchiolitis who is older than a month but still relatively young? The critical time is 48 weeks post-conceptional age. Let's take an example of 2 infants, both of them 4 months old, both with runny nose, and now with 1 day of wheezing and coughing. They're both symptomatic, but if we can get them to drink after suctioning, we can then decide who can go home. But wait, one was born at 31 weeks gestational age. Does he pass his post-conception prematurity test? Well, let's see. He's 4 months old today, so that's 16 weeks. Okay, so 31 plus 16, he is 47 weeks post-conceptional age. Even at 4 months old, he still carries somewhat of a risk for apnea in RSV bronchiolitis. Premature babies need extra thought and care in bronchiolitis. They just have to be old enough to have some respiratory reserve. You can see how we sometimes just need to take that moment and get the history correct. Think of it like when you were immature at school. It's like preemie detention. Just being premature causes us to hold you back in your dispo quite some time. The main thing to remember: premature, make sure that child is greater than 48 weeks post-conceptual age to gauge his risk for apnea and RSV bronchiolitis. Okay, you've got this. You've made the diagnosis. You're ready to manage this child. Now what? Who can go home? What can I do to make the child feel better? How can I provide supportive care like a boss? We'll go quickly through each modality and get us up to date. While we go through this, remember these governing rules in bronchiolitis. In the full-term child, greater than 1 month and otherwise healthy, so no cardiac disease, no neuromuscular disease, no pulmonary disease, we can look to 3 simple criteria for home discharge. If the otherwise healthy child 1 month and older is euvolemic, not hypoxic, and well-appearing, he can likely go home. The younger he is, the more work of breathing he has, the more dehydrated he is, the other medical comorbidities, all of these things make the chances of a safe discharge start to disappear. Clinical scores don't help. A crystal ball doesn't help. Just remember these parameters: age, post-conceptional age of 48 weeks, comorbidities, work of breathing, respiratory rate, volume status, and overall appearance. These will help you make the right call. The happy wheezer who's not too symptomatic? Good precautionary advice and follow-up. The obviously sick child, you resuscitate and support the airway as needed. But the vast majority are in-betweeners. Now what? Well, everybody should get suction because it just makes sense. But what about all of the other things that we can do in the ED? Let's run through each modality and intervention and go over the pros and cons of each. The chest x-ray is one of those things that make us feel better for getting it, but for the most part, it doesn't benefit the patient. The majority of plain films in children with bronchiolitis are normal or show the typical changes consistent with simple bronchiolitis like peribronchial thickening, hyperinflation, and atelectasis. Well, what can it hurt? X-rays will make everyone, including the parents, feel better, right? Well, if we were talking about simple skeletal films, sure. But several studies show an increase in antibiotic prescription after radiographs are taken that show non-specific findings that influence our decision. Look, I've been there myself. Resist the temptation if it wouldn't change what you would do. Factors that are predictive of a definite infiltrate are significant hypoxia, so an oxygen saturation of less than 92%, grunting, focal crackles, or high fever, especially greater than 39 degrees Celsius. In other words, get a chest x-ray in children whom you believe to have pneumonia rather than bronchiolitis. Which brings me to another issue. Keep your differential diagnosis open. Is it bronchiolitis or, say, a foreign body? Chest x-ray may help in this case as well. Speaking of imaging, what about ultrasound? We have better evidence for predicting pneumonia with ultrasound in children, but what about bronchiolitis? There are 2 small studies, one by Caiulo et al. In the European Journal of Pediatrics and one by Basile et al. In the BMC Pediatrics, that show some preliminary data, but they're not enough to change practice yet. So, chest x-ray. Get it if the child is severely ill or if you think there could be a pneumonia there. Not to verify that it's bronchiolitis. That's a clinical diagnosis. Now that I've taken away your chest x-ray, what if I swipe away that point-of-care viral test? Egads is right. But PCR is awesome. It's rapid, it's reliable, right? Yes, but you've already made the clinical diagnosis. Qualitative PCR gives us a yes or no question, and it's one you've already answered. It's not recommended for routine use just because it wastes time and money in bronchiolitis specifically. You also may get a false positive. Rhinovirus is a lazy squatter that just hangs out, either as a colonizer or it just gives you prolonged shedding from a previous illness. If you find RSV or human metapneumovirus, however, that usually means there's an active infection. It's normal to shed the virus for more than a week, and your PCR will be positive up to 10 weeks post-infection. In some patients, PCR may be positive for much longer than that. In one study by Lerner's et al., immunocompromised children sometimes were asymptomatic RSV carriers for more than 90 days. Okay, back to reality here. It is true that quantitative PCR can give you the viral load, and an increased quantitative viral load is associated with increased length of stay, use of respiratory support, need for intensive care, and recurrent wheezing. But again, your clinical assessment will get you there. There is one instance in which viral testing in bronchiolitis can be helpful. In babies less than 1 month of age, the presence of RSV virus is associated with apnea. The effects in this very vulnerable age are both peripheral and central. Test the neonates for RSV if at all possible, and of course, they're getting admitted. Depending on your institution, the inpatient team may ask for RSV testing to be able to cohort children upstairs. This has not been shown to be any more helpful than the normal precautions of hand washing and keeping them at least 1 meter away from each other on the ward, but if it helps my friendly neighborhood pediatrician, I'll do it. You've resisted the chest x-ray. You've softened on viral testing. Now, am I going to take away your urine? Routine testing of blood or urine is not recommended for children with bronchiolitis. Levine et al. In pediatrics found an extremely low risk of serious bacterial illness in young febrile infants with RSV. The main thing here is not to give in to anchoring bias. If an infant of 3 months of age or older has a clear source for his low-grade fever, and that's his bronchiolitis, then you have a source, and very rarely do you need to go looking any further. He's showing you the viral waterfall from his nose and his increased work of breathing. It's just not going to be in his urine. Having said that, if the predominant presentation is fever, and you can't pin it all on the bronchiolitis, just because everyone around him is sick with the same, then by all means, evaluate him as a young infant with fever and investigate. For babies less than 3 months of age, even if you feel this could be bronchiolitis, be more conservative and consider a further workup in the doubtful cases, but not as a routine measure. We've made the diagnosis. Let's talk treatment now. Should we use bronchodilators in bronchiolitis? It seems lately that this is a loaded question, with strong feelings on either side amongst colleagues. The short answer is that the American Academy of Pediatrics, the UK's National Institute for Health and Care Excellence, as well as the Canadian Pediatric Society currently recommend against them. However, in continental Europe and Australia, the language is softened to not routinely recommended. What's the big deal? Why the disagreement, and why can't we just give them a try? The reason it's confusing is that there really isn't great evidence either way, and many organizations see their role as, how can we do the most good for the most people? In defense of the AAP guidelines, it wasn't too long ago that community providers would dispense liquid albuterol or salbutamol, all of the systemic effects with no real benefit. The goal of these organizations is to rein in overtreatment. Here's the problem that many have with the current guidelines, and I'm going to include myself in this camp. The previous guidelines stated that, quote, it may be reasonable to administer a nebulized bronchodilator and evaluate clinical response. Individuals and institutions should assess the patient and document pre-therapy and post-therapy changes, unquote. They cited that 1 in 4 children treated with bronchodilators might have a transient improvement. It made sense to give them a try based on judgment. Now we see a hard line about face. Thou shalt not use bronchodilators in bronchiolitis. So, what happened between versions of the guideline? There must have been some great trial, or a new preponderance of evidence to the contrary, or case reports of harm. Nope. In fact, the 2 committees used the exact same studies to come up with divergent recommendations. From a global perspective, I personally would not like us to continue to flog children with obvious bronchiolitis with increasing doses of inhaled bronchodilators. On the other side of the coin, is it worthwhile to perform a trial of bronchodilator in bronchiolitis? Absolutely. At least according to the data that we have available, and according to just about anyone working in the trenches who sees a wheezing infant in the ED. Remember, guidelines are all about population health, not necessarily the individual in front of you. That's your job. Your job is to tailor care, especially if the child has a history of atopy or wheezing. The bottom line is, guidelines frown upon the word bronchodilator even muttered in earshot of a broncholytic. I say bronchodilators are not a cure-all, but worth a 1-dose trial and a prompt re-examination to gauge any benefit. We're savvy enough to quickly change gears depending on response. Ooh, it just got a little hot in here. Let's keep going down the list of banned substances. Ah yes, steroids. Funny story, they used to be all of the rage in bronchiolitis, but have fallen out of favor based on good studies to show us no real benefit. Even when we look at a subpopulation of children who have a strong family history or a strong personal history of atopy, steroids just don't do much at all in bronchiolitis. After multiple studies, including 2 large multi-center trials and a Cochrane meta-analysis, we can all agree that steroids for bronchiolitis are just lame. Okay, now let's branch out to the more reputable remedies. What about nebulized hypertonic saline? I mean, there's a lot of debris in there with mucus plugging. Maybe we can soften the secretions. Well, that's how it works in other respiratory disorders like cystic fibrosis, where it rehydrates the airway surface and helps mucociliary clearance. This is a good example of why it matters to be careful of the population sampled and the methods and measures used when conducting a study. Initial trials of nebulized hypertonic saline in bronchiolitis involved hospitalized children, especially in children with hospital lengths of stay longer than 72 hours. Subsequent systematic reviews and meta-analyses bolstered the evidence of this effect in admitted patients. Later meta-analyses found substantial heterogeneity in the studies. So basically, the studies were significantly different from one another, that pooling the data was difficult. On the other hand, the problem here may be that we are asking too much from a single intervention to make a dramatic difference. Will hypertonic saline turn around a child with bronchiolitis? No way, no how, no matter how long he stayed. Is it worthwhile to do in-house? Sure it is. Based on this data, it wouldn't make sense to administer nebulized saline to a child in the ED who was obviously going home. There just isn't any benefit in the short term. If your patient is definitely admitted and the nebulized hypertonic saline does not interfere with other treatments or it doesn't delay care, then go for it. Now it gets real. What about nebulized epinephrine? Just when you thought we were finished with the whole nebulized thing. A randomized controlled double-blinded study in 8 centers in Norway published in the New England Journal of Medicine showed no benefit to nebulized epinephrine over nebulized saline. Again, probably asking too much of one single intervention. This one's not the magic bullet either. The Cochrane Review found 19 studies that included a total of 2,256 children with acute bronchiolitis treated with nebulized epinephrine. There were no differences in length of hospital stay between the placebo and treatment groups, and so they concluded that for inpatient, nebulized epinephrine is not worth the hassle. However, and this may just be an artifact of the meta-analysis, there may be some benefit to outpatients. One study of combined high-dose steroid and epinephrine therapy was not statistically significant when other factors were controlled, but Cochrane concluded that nebulized epinephrine itself may be helpful for outpatients. It won't affect the overall disease time course, but it may make the patient feel better enough to go home from the ED and continue observation there. So, in the child that you think could go either way, it's reasonable to give 0.5 ml racemic epinephrine or adrenaline at 2.25%, diluted in 2 to 3 mLs of saline, or simply 3 to 5 mLs of standard adrenaline, the 1 to 1,000, nebulized times 1, and monitor response. Just remember the risk to benefit ratio of any intervention. In this child in front of me, do I think that nebulized epinephrine will reduce his airway edema or just upset him and make him more tachycardic? Choose your own adventure. Let's talk about children with bronchiolitis who you know are going to stay. You've tried suctioning. You've tried rehydration. Your little patient is improved initially, but he seems tired and less interactive. We always have to be concerned with a mounting metabolic acidosis. Surely the persistently hypoxic child with poor interactiveness and tone needs endotracheal intubation. But what about the child who is just seemingly tired with increased work of breathing? As with anything we've reviewed here in bronchiolitis, we can't expect dramatic effects with any single intervention. A high-flow nasal cannula involves specialized equipment and delivers humidified oxygen at 1 to 2 liters per kilogram per minute. That's quite a bit for an infant. In addition to oxygenation, high-flow nasal cannula also likely offers some low-grade positive end expiratory pressure. In bronchiolitis, this doesn't help so much with the ventilation. The baby is breathing at 70 respirations per minute. It helps more with alveoli recruitment. The evidence for its use is based on observational studies which have found improved respiratory parameters and reduced rates of intubation. High-flow nasal cannula is certainly worth a try in the child who is still well enough not to need endotracheal intubation. Nasal CPAP also has some promising properties in the right clinical setting. Antibiotics. You aren't going to give them anyway, right? I know you. You're better than that. But sometimes it's not so clear. Is that finding on the chest x-ray atelectasis or pneumonia? Now, it is true that macrolides have anti-inflammatory properties separate from their antimicrobial properties, and there is some data showing an in vivo decrease in interleukin levels. But when bronchiolitis is from a clear viral source, the risk of accompanying bacteremia is less than 1%. A meta-analysis of randomized clinical trials found that antibiotics in bronchiolitis did not improve duration of symptoms, length of hospital stay, need for oxygen therapy, or hospital admission. Maybe you truly believe there is a bacterial pneumonia present, like a superinfection with worsening fever and respiratory symptoms after a prolonged course. If not, and you've made the diagnosis of bronchiolitis, then resist the urge of a chest x-ray. You're only throwing dice that you'll see something you'll react to and throw antibiotics at it. The single radiation dose is not a big deal unless the child gets them all the time, but the risk of developing antibiotic resistance for the population is real, and at the very least, a real risk of bonus diarrhea without any benefit to the patient. All right then, who should be admitted? First, let's start with the baseline, what everyone would agree with. Respiratory rate 60 to 70? Slam dunk. Hypoxic to 88%? Yes. Not taking fluids or poor appearance? Check. But we already knew that. Certainly any child in persistent respiratory distress, risk factors for deterioration, or just very young, like less than 2 months of age, we really should be considering admission. It's rough though, and if you work in a busy department or in a children's hospital that gets a tsunami of sneezing and wheezing and bronchiolitis, you have to be more selective with who stays and who goes. There is even some prelim research on sending hypoxic children home from the ED on oxygen. That may work after a defined hospital course, but for now, we can say that DC from the ED on home O2 is not ready for prime time. What we all have trouble with is in the in-between cases. The guidelines quibble over trying to distinguish disposition in a very narrow group from 90 to 94%. There was even a recent study that modified the pulse oximeter to show 94%, even if the child's oxygen dipped to as low as 90%. According to the authors, a discharge saturation of 90 versus 94%, there was no difference in the outcomes. I would just caution that it all comes down to context. There is a dynamic nature to bronchiolitis. If the 6-month-old who has a saturation of 91% at some point in the ED visit, but then he jumps up to 94%, then 93%, then 95%, and he's well-appearing, euvolemic, and has good supportive care at home, I'm not so worried. The child who is persistently 90% and huffing and puffing is worrisome. Not only from a physiologic standpoint, but just from a common sense one. We know that the oxygenation curve drops precipitously at 90%. Why are we making the cliff our line in the sand? I think what the guidelines authors are saying is that we overtreat and we over-rely on pulse ox. Overtreat? Possibly, but a trial of bronchodilators in the older child who may have reactive airway disease, why not give it a try? The guidelines are meant to treat the population, not the individual, so we get it. Use your best judgment. These are guidelines, not sanctions. Do we over-rely on pulse ox? Well, that one's tougher. I would say that I'd rather err on the side of caution. If your typical patient has no ready access to primary care, or the family needs to take multiple buses to get to your ED, then an oxygen saturation of 92% will bother me. You just have to make the best call you can, given the patient, the parents, and the circumstances you have. And remember, guidelines do not replace or override your judgment. Don't let anyone bully you into going by the letter of a made-up law. By the same token, if there's an opportunity for clarification or collaboration or observation in conjunction with the admitting team, then by all means take advantage of it. Nobody really knows what the right treatment is. Our job is to support them while nature heals and to make sure that they're safe. Guidelines are not marching orders. Be aware of them and use your best judgment. In summary, bronchiolitis can be tricky because it varies with age, by onset of symptoms, and even varies right in front of you as mucus plugging and unplugging happens. So, what's the good, the bad, and the ugly? The good. Suction and hydration are your best allies. You may elect to give a bronchodilator as a trial once and re-examine if you're a bronchodilating believer. The bad. Steroids, antibiotics, and a blind obeying of the guidelines. Weigh the risks and benefits of every intervention, including hospitalization. It's not always a benign thing. The ugly. Take a moment to assess the child and make a clinical diagnosis of bronchiolitis after you've excluded cardiac disease, anatomic anomalies, and foreign body aspiration. Wheezing without upper respiratory symptoms is not viral and it's not bronchiolitis. And when all else fails, remember, in the otherwise healthy term infant greater than a month of age, if he is well-appearing, euvolemic, and not hypoxic, he will often do well with good precautionary advice and supportive care at home. Everything else, be skeptical, be thorough, and above all, be careful. Thank you for listening. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.